Day Lunch and Learn. I'm Carol Bold, a member of CERAH. A few notes before we get started. I'd like you all to know that this session is being recorded and it will be posted on CERAH's YouTube channel. Also, you afterwards will be getting a copy of a PDF of this presentation. All the registrants will be getting a copy of this presentation. During this session, we appreciate if you would keep yourselves muted so we don't hear any background noises. Questions and answers for this session, we would like them to be held off to the end of the session. Of course, if you have something very important that you don't want to lose track of, feel free to speak out or put it in the chat. Otherwise, let's wait till the end of the session, please. And also, we're going to have another Lunch and Learn event on Wednesday, April the 14th, and it's going to be about advanced care planning. More information will be going out and being posted on CERAH's events page, so look for that. So I'm happy to introduce today's speakers. We have with us Lynda McKeown and Heather Woodbeck. So for over a decade, Lynda and Heather have been working to improve oral care for residents in long-term care homes. And recently, their co-authored article entitled "The Hidden Wound Epidemic in Our Midst" about oral care was published in the journal Wound Care Canada in 2020. So we really are lucky to have them here with us today to tell us about oral health care. So Lynda McKeown is a registered dental hygienist who received a diploma of dental hygiene from the University of Toronto, an honors degree in philosophy, and a master's degree in sociology from Lakehead University. She's a researcher, activist, administrator, mentor, and veteran volunteer whose career spans more than 5 decades and has involved working with people of all ages and working in many sectors and areas of healthcare, including private practice, public health, education, research, and oral care in long-term care homes. She was appointed to the College of Dental Hygienists of Ontario Transitional Council by the province, and she served as the first president of the College of Dental Hygienists of Ontario. She was also the first administrator, researcher, and clinical therapist for Dr. Marlene Bloom's Breath Odor Clinic in Thunder Bay, and she's a published researcher on the topic of breath odor. Heather Woodbeck is a registered nurse who received her Bachelor of Science in Nursing degree from Lakehead University and a Master's of Health Services Administration from Charles Sturt University in Australia. Her nursing background in Northwestern Ontario was broad. Earlier in career, she worked in women's surgery. She coordinated the grassroots Northwestern Ontario Women's Health Education Project, and she was an instructor at Lakehead University who focused on teaching obstetrical nursing. She gained extensive experience in cancer prevention and screening as the first administrator of the Northwestern Ontario Breast Screening Program and as the inaugural Director of Preventive Oncology at Northwestern Ontario Regional Cancer Centre, where she helped promote one of the first bans on smoking in public places in Thunder Bay. Currently, she is the RNAO Best Practice Guideline Coordinator for Long-Term Care Northwest Region, where she assists long-term care homes implement evidence-based care. Welcome both Heather and Lynda, and I'll give it to you, Heather.
Okay, thank you for your kind introduction. So the way that Lynda and I have set this up today is we're going to take turns and go back and forth. If you have any problems hearing, either let us know or throw that in the chat box, please. We may have to go off video because sometimes that affects things. So first off, we're going to start by I'm trying to start. This is what you said would happen, Carol, is happening. Okay, let's see.
What you might want to do is stop sharing screen.
Okay, stop share.
And then you're gonna take it off of the slideshow mode.
Okay.
And now start sharing screen again.
Okay, I think
so take it off of slideshow mode and start sharing your screen again, and we'll see you put it on slideshow mode, but that should fix it.
Okay, let me see. How do I do this? Okay, sorry about this. Technical difficulties here.
It happens, so
Yep, okay, so it's
Someone would
off
sing a song or
sharing
something.
right now, and then I need to put it back into slideshow.
Well, not yet. Put it right now,
Okay.
share the screen before you put it in slideshow mode.
Okay.
So we'll see you putting it
Okay,
in
now it's
slideshow
not
mode.
allowing me. Okay, let's just see if I can get it to me. Okay. Oh, joy.
Yeah, just hit escape from the slideshow, hit escape. Sorry, everybody. I could try to pull up the PDF if you wish.
Okay, escape.
Try it one more time.
Right. Let's try sharing the screen. Yeah. Okay.
Sorry, everyone. We'll be with you in a moment.
Okay, so I cannot, so can you see that? That's got the screen in, but I cannot get it to stop.
Yeah, okay. You just have to, can you hit escape from the presentation? I'm going to pull up the PDF in the meantime.
Yeah, good idea.
Interesting how this worked just fine in our practice.
One moment here. You could stop share screen. I guess you are stopping. Okay.
Yeah, I have stopped that. It's not allowing me to do anything here.
Now, how's that?
Yep. Okay, so we'll go to the next page, which is our acknowledgements. And we just wanted to acknowledge that this presentation is based on earlier presentations that were done back in 2011 and 12. At that point, end of life and palliative oral care were kind of a hot topic, and we had an oral health community of practice run through the Seniors Health Research Transfer Network. And there was a lot of information out there on oral care and palliative oral care in particular. So in the time since, we've only found a couple of presentations that have been done. So I think this is why this is a timely topic for many of you. Next slide, please. So our objective is to understand the need to provide palliative and end-of-life oral care, help you become aware of common oral conditions that can occur during the palliative and oral care and end-of-life stages, and then to learn some best practices for optimal palliative and end-of-life oral care. Next slide, please. So we've used this older definition of palliative care, and it's an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early detection and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So for those of you that are really involved in the palliative care community right now, you're going to notice that's a big difference from what we're using now that's accepted as palliative care. Currently, the focus is on the last year of life. The Registered Nurses Association has done a best practice guideline on that I'll talk about a little bit later on. And as well, the Health Quality Ontario, which is now part of Ontario Health, has an initiative aimed at improving palliative care, the end of life, and they've put it on, they also have focused on the last year of life. But in dental hygiene, palliative oral care is when the person becomes dependent on someone else for mouth care. Next slide, please. So end of life doesn't have a really super clear definition. We've taken the one from the RNAO end of life best practice guideline, and that focuses on keeping the mouth moist, clean, and comfortable in the last days and hours of life. So that's looking at probably the last few weeks. For those of you who use scales, that it would be when the palliative performance scale hits 30% or less. Next slide, please. So we want to emphasize that oral care goes from cradle to grave. We often don't think too much about the mouth. The Western medicine in particular has pretty much studiously ignored the mouth. It's been a really interesting experience for me to work with Lynda and a couple of other dental hygienists and a dentist to work on we're on our second article now on dental or oral issues, and to realize how much knowledge and information dentists and dental hygienists bring, and yet, and how much they appreciate the importance of what's in your mouth, and how little, as a nurse and healthcare provider, I even understand about it. So it's really important to communicate, to eat, to look good, and for having fresh breath. Next slide, please. So the mouth mirrors the body, and this slide's a little bit hard to read, but basically what we're starting to see in a lot of research now is what's in your mouth is what's in your body. So if you're seeing somebody with periodontal disease, you really need to say, well, what's going on in that person? It's not just about their mouth, it's often about the rest of their body. It could be a sign that they actually have a cardiovascular issue. And that keeping your gum, the other thing is that in our article that was appeared in Wounds Canada, we talked about the importance of gums and teeth and keeping your gums clean, because that's where oral care wounds develop, and those wounds are actually portals for infection into the body. Next slide, please. So this is some of the conditions that, this is a slide or a handout that the Manitoba School of Dentistry has done. And it talks about how you can get diabetes, heart and stroke, respiratory diseases. We found a couple of little articles, newer ones that are suggesting that COVID-19 could be detected in saliva and possibly could be transmitted into the lungs from the mouth. There's some interesting research even being done on tests in saliva for COVID. Next slide, please.
So this, as the mouth ages, we look at it's differently. Not every mouth ages in the same way, and very often people become dependent. In the slide on the picture on the upper left, this woman, I first met her, she was living in assisted living in she was a tenant in an apartment complex. At that point, she was still able to go out and access her dental office for dental treatment if she needed teeth repaired. I followed her along when she moved to long-term care home when she needed more dependence, and I helped her maintain her mouth until death. The picture on the upper right is an example of what happens when debris, when the mouth is left unclean. Those black spots that you can see in there are defects in the teeth, and the intent of keeping the mouth clean and the debris free off the tissue and off the teeth is to prevent disease. In the bottom right picture here is a picture of extensive mouth care where there's crowns and bridges, and in ambulatory folks that are able to look after their own care, that's a challenge. It becomes almost, well, it's impossible. That's not possible for a personal support worker to be expected to look after. Next slide, please. So more challenges for oral care and long-term care. These pictures represent of somebody who's had full mouth restorative done on implants, and so these are prosthetics. This is another example of this mouth is very hard to clean for the person who is quite able, cognitive and physically, to be able to, really quite impossible actually in that case, and truly impossible when it comes to a long-term care situation. And I watched third-year dental hygiene students have some challenges cleaning a mouth like this, and to expect that personal support workers can do it is just beyond the beyond. Next slide. So this is Anne's story, and this is an example of one of the main things, I think one of the issues, well, for me, one of the issues is that the oral healthcare professionals are not in long-term care health legislation. They're not in the Act. And so this leads to many issues, and this being one of them that is an example. With the COVID-19 pandemic, dental hygienists were declared non-essential healthcare providers in March of 2020. And Anne's story illustrates the neglect that can occur in the mouth. Anne is totally dependent on staff for all of her care, including her oral care. And she, under normal circumstances, non-COVID circumstances or flu influenza, has weekly dental hygiene therapy to remove the oral debris. So the dental hygienist was back in August. Next slide, please. So it wasn't a pretty picture, figuratively and literally. You can see there's all kinds of debris and food in Anne's mouth, around the teeth and around the gums. The oral assessment found that her gums are red and they're swollen. And as you can see, bacterial debris and various debris coating the teeth and the gums. There was a personal support work student who was on a practicum, and I thought, came into the room and I thought, well, this is a good opportunity for doing a little bit of teaching and sharing some of the knowledge and experience. And so I was explaining to him how it's really important to have the toothbrush around to get the gums. If you're going to get the gums clean, you probably get the teeth clean as well. And he said, I didn't even know Anne had teeth. Next slide, please. So the dental hygienist did the non-invasive debridement and removed the debris. A non-invasive debridement means not using these sharp instruments, but using what we call as oral physiotherapy tools to remove the debris. In most of the cases, the debris in the mouth is quite soft, and with various oral care tools can be removed. So I think you could see that by first sanitizing the mouth and then the non-invasive debridement here, that the mouth looks much cleaner. Next slide.
So I think
back to you, Heather.
That's me,
Yeah.
that's right. So this slide, I hope you can read it, but it talks about the different, it's just a nice overview of all the palliative oral health issues that can occur in either that last year or when people start to not be able to do all their own care. So we've circled things like pain, xerostomia. Xerostomia is a fancy word for saying dry mouth. And it is related to a lot of different medications. There's about 400 of them that cause dry mouth. So you can see a line going up from xerostomia to antidepressants. As well, alcohol mouthwashes can dry out, contribute to xerostomia. Narcotics. The trouble with that is then it affects your ability to taste. It affects your even your ability to swallow when you have xerostomia. It contributes to cavities or caries, as we've got here, because you need saliva on your teeth to prevent bacterial growth. So poor, and then you can see how that's connected to poor oral hygiene, like in Anne's story, where her teeth got missed, and we understand that. It's been a huge challenge in long-term care over the last year now. You can also see that once you get breakdown, you get things like candidiasis, stomatitis, mucosis, and there's other things that contribute to this. It's pretty commonly seen in cancer patients with chemotherapy and radiotherapy to the head and neck. And we've got some nice links to resources that could be useful for that population. So next slide, please. So at the end of life, oral health persons require special attention because their oral health can fail pretty rapidly. The stats show that 89% of those who are terminally ill with cancer have at least one oral symptom, and that general health and comfort are closely linked with oral health in the terminal stages of diseases. So here's some more of the issues. Dysphagia, that swallowing difficulty. And this is because the saliva actually helps us to form a bolus up with the food. And the old adage of chewing your food well is really important, that you need that start digestion, because there's enzymes in the saliva. You'll have to look for our next article because it's pretty interesting how magical saliva is. You can run into things like aspiration pneumonia that I mentioned earlier. Then nutrition, hydration, and taste alterations. If your mouth's full of scuzzy things like Anne's was there, your food doesn't taste right. You can get sore lips, dentures, so if they're not removed every day and cleaned, they can actually start to abrade the tissue. With xerostomia, you get this really thick, disgusting mucus, which I think we've got a picture further on just to show you. You can have difficulty speaking, like because we need saliva to help the insides of our mouths move. Saliva is really what keeps our mouth from shutting down and gluing itself together, because it is like it's a piece of skin that's inside our mouth. It's got all the same properties as skin and more. We mentioned all the other ones, nausea and vomiting. We didn't mention, and general infections, that if you get one infection, you're open to infections from other bacteria that may or may not be treatable with antibiotics. Next slide, please. So common oral conditions, the challenge with these oral health is that you get complications concurrently. So you can have a cancer patient that they've actually got oral pain, they've got mucositis. Sorry, Lynda, you're gonna have to help me with that one. Xerostomia, dysgeusia, which is again the lack of taste, and a fungal infection at the same time. So you can see how sore that person's mouth would have been just by reading that list of everything that's going on there. Next slide. I think this is where you take over, Lynda.
Candidiasis. The usual manifestation of candidiasis is thrush, and that shows up in about 90% of the patients who have cancer. And the risk factors may be recent chemotherapy, radiation therapy, antibiotic treatment, corticosteroids, smoking, xerostomia. And the clinical findings are usually painless. There's a number of ways it may show. Painless white strands, flecks, or patches resembling cottage cheese that adhere firmly to the underlying mucosa, and they'll bleed if you scrape it off. You have to be careful. And lesions may develop in actually any part of the mouth. Next slide, please. Next slide, please. So xerostomia, as Heather has referred to, dry mouth, main cause from a lot of the over-the-counter medications. There's at least 500 medications that can cause xerostomia. Can cause it, but doesn't always cause it. And I'm not going to go into a lot of details. Heather and I have been learning so much more about the saliva, and so dry mouth can, as I say, be caused by a number of things, but the reduced saliva flow will result in less natural washing away of the oral bacteria. And when you look at that, back at that picture of Anne, that's one of the, she's got less saliva in her mouth. And so the actual natural activity of washing away that bacteria is not happening. And it's important that the debris, the oral biofilm, and the bacterial plaque are removed on a daily basis for health. Next slide, please. So this is what Heather was talking about, these pictures here. In both of these pictures, there, as you can see, there's thick mucus. This was a resident who was being tube fed, and that mucus can get very, very dry. It sticks around the tissue, and it has to be taken off very carefully. If it's left there, it's going to cause damage and inflammation to the tissue, which is inflammation is a huge issue because that's the connection with the whole body. And so that needs to be removed. Next slide. So again, the impacts of when your mouth is dry: difficulty with chewing and tasting, becomes more difficult to wear dentures. Often there's nutritional compromises, which might mean eating softer foods. There can be burning sensation in the mouth or the tongue. Difficulty speaking. Any of you who've had dry mouth, it's pretty awful when you got your tongue stuck up on the palate of your mouth and you can't seem to get it to move. And there may be esophageal dysfunction, increased intoleration to medications. There might be halitosis, sore inflamed tongue, candidiasis, angular cheilitis, bacterial infections, a loss of the oral buffering capacity. The normal pH in the mouth somewhere between 6.2, 7 something, and the saliva is very much important in that balance. And so when that balance is lost, there's an increased risk of mucosal injury. And as Heather mentioned earlier, there's a marked susceptibility to defects in the teeth, to caries, and there can be decreased socialization. Next slide, please. So in the case of extreme dry mouth, as I said, the mucus is a problem. So it's best to start the cleaning process with a wiping. Use a clean, dampened washcloth or gauze wrapped around your finger and dampen this with water, or we haven't mentioned the rinses yet, but one of the rinses that we'll talk about in a bit is the chlorhexidine. Wipe the inside of the mouth to scoop out the mucus and any pocketed debris. And might have to do this a few times to clear the tissues before you can proceed to cleaning the teeth and the gums. Next slide, please. And oral mucositis, this is a soft tissue issue, extremely painful and sore inflammation in the mouth. About 5 to 15% of the cancer patients will develop mucositis or stomatitis. Chemotherapy and radiation therapy can cause oral mucosal changes and cellular death. And so, of course, it disturbs the homeostasis of the mouth and body. Common side effect of chemotherapy, this will sometimes occur about 3 to 10 days post-treatment, and then can improve. And as Heather mentioned before, one of the things is this taste blindness, this inability to taste anymore, or taste properly. About 50% of cancer patients receive head and neck radiotherapy, and they may develop mucositis, but a large percentage of them. And this will occur about the second week and can last for 6 to 8 weeks. Next slide, please. Your turn, Heather.
Mine. So it's pretty important to assess the mouth carefully. And we've had some good talks about this. So you want to start by looking at their medical and dental history if possible, if they're in long-term care, and even if you're working in acute care or at home care. Find out, do they have an oral health practitioner? Have they even had oral care? Some people haven't had oral care in the past at all, and others, like some of Lynda's clients there, she's had them for years. They've taken excellent care of their teeth through their entire life, and their oral health is really important to them. So establishing where they are in that range is important. We've talked about medications, and there's all these 500 medications that contribute to xerostomia. You can look for changes in medications. It's pretty important to understand that the basic, narcotics contribute to xerostomia, and then any of the anticholinergics as well do contribute. Then look at them from the outside. Look at their face. Like, look at physical changes that in the resident that they're not capable of doing their own oral care, and they might have arthritis. They might be unable to walk. Often there can be cognitive changes, particularly if they're in long-term care. We have to remember that oral care requires executive brain function, and likely if help is needed with toileting and feeding, then likely help is also needed with oral care. And I'll just share a little story here where Lynda and I were working together with in one of the homes with a client of hers, and the woman had absolutely amazing teeth that were filthy when we saw her, but when we asked, she said, "Oh, no, I've cleaned my teeth." So unfortunately with her, she had forgotten that she hadn't cleaned her teeth, and so you could tell she had, until that time, had taken very good care of her teeth and had all her teeth intact. And then now, in forgetting that she hadn't cleaned her teeth, she's going to put herself more at risk for having caries and losing teeth. Next slide, please. So then you want to start peeking inside the mouth and looking around. Look at the lips first. Again, on the outside, are the lips, are they dry? Are they cracked? Does the mouth look dry? Are there any sores in the mouth? Like the one question came up of what's angular cheilitis, and I don't know if we have a picture of that, but that's where you get sore redness at the corners of your mouth, and the skin starts to break down. So you can see that from the outside. You can see if they have things like herpes lesions, and look for all of that. Check for oral pain. Oral pain is hugely important. It is an undiagnosed and unrecognized contributing factor to behaviors in long-term care. Sometimes people with dementia can't express that they're having pain, and they'll lash out, particularly if you try to do oral care, if you try to feed them. Once you can get them to open their mouths, and you might have to look at, having them in the bathroom or where a place that's familiar for doing their own care, look for bleeding. Look for, you can ask them about changes or see if they're eating less. You can look for swallowing issues, the teeth and gum issues. We've had some lovely pictures with all the food and debris on there. And then are the gums puffy? Do the teeth look broken? In the one picture, the resident clearly had a broken tooth. Look at how their dentures fit. Do they even want to wear their dentures? Refusing to wear dentures is usually a classic sign that something's wrong, that their face has changed. Maybe they've lost weight, but those dentures don't feel good anymore. So yeah, those are some of the things to look for in an oral assessment. I think the next one's Lynda's slide.
Right. So these are some of the oral care interventions that can be done by professional dental hygienists. This top one is interim stabilization therapy. The goal for dental hygiene palliative oral care is to keep the mouth clean and comfortable onto death. And this may not look so pretty on the top here. What it is a temporary material with zinc oxide, which has a healing effect, and a slow release fluoride. And there were defects, obviously major defects in the teeth, but this is one means of supporting those teeth until death. So again, palliative oral care, the goal is to keep the mouth clean and keep it comfortable, and keeping in mind, this is kind of a gross way of putting it, but people understand this when you say you should use the same principle with regards to the mouth and the oral debris, the removal of the oral debris, as for fecal incontinence. We don't leave people unclean like that. So it's important to remove this debris for the comfort and sanitation of these folks. Next slide, please. So the first is to remove the debris so that we maintain the health of the teeth and the tissue. You can see here around the gum line, the plaque and the biofilm around the teeth and the gums. And in some cases, this buildup will cause an odor, but not always, but it's indicative of the fact that there's a lot of debris around the tissue, and it's causing inflammation. And that's really my main concern, is I really don't like to see that oral tissue inflamed in any way. So it's very important that is removed. Next slide, please.
Just, Lynda, this one's got just a perfect example of puffy red gums that are easy to see when someone opens their mouth. Eh?
Well, it's easy for you now, Heather.
I've been well trained.
So cleaning the mouth, we talked a little bit earlier about the rinses, but instead of toothpaste, I use a 0.12% chlorhexidine, and this can be prescribed in long-term care by a dental hygienist that's been authorized to do that, a doctor, a nurse practitioner, or a registered nurse. And the reason, this is a different brush, we'll talk about this a little bit further along, but the chlorhexidine is an oral antimicrobial, and it helps to rebalance the oral flora. It reduces the gingival inflammation and bleeding, and it's substantive and remains on the tissue for a long time. And this is talk about a little further on, but it's a dip-in brush, so don't have to worry about people spitting, or for the most part, or it's not too messy. Next slide, please. So brushing the teeth and the mouth. We think of when really thinking about toothbrushing, we think about brushing the teeth, and really that's not the main place. But a couple of things with regards to the brush itself. The toothbrush, in this particular case, when we're working with somebody that's dependent on us for oral care, a longer handled brush is helpful. So you can extend it back to the back of the mouth, to the molar areas and around the gums. And this has it's a small head on it, so it fits well in the back, and it's also soft. And as I said, using a small amount of the rinse, so we use a dip and clean method, dip a little bit of dip the brush in a little bit of chlorhexidine and clean the mouth like that. And also, as I got down on the bottom here, the oral physiotherapy tools that the dental hygienists use in long-term care would include dental floss, and all of these things can be dipped in the chlorhexidine so that you have that antimicrobial effect as you go along. Next slide, please. Now, this is really crucial for all of us. Those of us that are ambulatory and those of us that aren't. It's important to adapt the brush so that the bristles overlap the gingival tissue. That is where the bacteria live. It's a very difficult, the interface between the teeth and the gums, and it's a very challenging area actually to clean. But if you think of the head of the brush actually as a soft cloth, and you're going to adapt the bristles in such a way so that you're massaging the tissue and wiping off the debris at the same time. So it's not a matter of like brushing your hair. So you run the bristles right across the face of the teeth. That part, if the saliva is functioning properly, the action of the tongue and the cheeks as we're talking and speaking will usually get rid of the big debris. Next slide, please. So toothbrushes and swabs, again, another picture of this particular brush. A small head is better for folks with teeth, as it's easier for whoever the helper happens to be to reach the gums around the molars and the back teeth. And preferably do not use swabs at all, and don't use glycerin swabs, as they will dry the mouth. The non-glycerin swabs can be used to moisten the mouth, and this would be at end of life only. Avoiding swabs at the rest of the time, you should avoid that just in case there's a hazard of somebody biting them and choking on it. Next slide, please.
They come off really easily. That was my part. I had to put that in. They come off really easily, and we don't think that could be a risk, but it could be a major risk for someone.
Best done by the professionals.
Yeah.
Okay, so now we're into some more of the oral care interventions beyond just the toothbrush on the teeth and the tissue. Denture care, of course, is very important. These are dentures that were from clients' residents that I was working with. The residents' dentures need to be cleaned on a daily basis. As you can imagine, these dentures are collecting a lot of bacteria, and when you put that next to the tissue, you're going to have disease and inflammation. And as I said, that's not something that we want in the mouth. So the dentures have to be properly cleaned and need to scrub the biofilm off. I think the next slide, please. Yeah, shows the denture brush here. The denture brush is extra firm because we're not cleaning live tissue. So you can scrub really hard with the denture brush. And you'll notice on the top two pictures where the calculus and plaque is on the denture, it forms there just as it would around your teeth and gums in your mouth. The little point on the denture brush there is used to clean into the palate of the denture. And so that point actually should be careful of that when you're buying a denture brush for somebody, that it actually fits. Some of them are shorter than others and don't actually go into it if it's a deep palate. That point can also be used to clean the clasp on a partial denture. Next slide, please. And at the end of life, as Heather mentioned earlier, people often will lose weight. And in that case, sometimes the dentures, quite often, when the dentures become loose. Or the other thing that sometimes happens is that if it's a partial denture, teeth may break. And when that happens, then they don't fit. So if and when the dentures become uncomfortable, take out the dentures except to eat.
And you can just, Lynda, one just point that I want to add here too is If it's earlier, like if they're more in the palliative stage, bring in a denturist, or because they can be relined, or even their dental hygienist can help to make those, help those dentures to fit a bit better sometimes.
Oh, yes. Yes, yes, there's many creative things that can be done, actually. Yes, that's a topic for another day.
Yes, but
Your turn,
just
I think. Your
people
turn or
don't,
mine?
I think it's still yours, but people shouldn't just put aside the dentures and think, well, they're no good anymore, because they can be fixed. It just requires a visit.
No,
with
that's
the-
true.
Yeah,
That's quite true. Or adaptations can be major. Yes, you're quite right, Heather, in that. So back to candidiasis treatments. Sometimes the chlorhexidine will help. It to rebalances the microflora in the mouth. Nystatin, which is an antifungal, is commonly used, and not necessarily right at the end of life, but when the candidiasis is present, it can be used as a treatment. That's an example. We've talked, I think both of us talked earlier about the homeostasis and the ecology, the microbiome, and how important what's going on, the complexity actually of the oral cavity that we don't reflect on very often, how it is, the system is out of balance, and candidiasis is an example of that. And you don't necessarily need to remove it, but if it's blocking the throat, then you want to get it out of the way.
because it can become like a big lump of mucousy looking stuff.
Well, you might not be able to swallow. Your
That's
turn.
right. Okay, so just we've summarizing that what the end of life oral care protocol has here is that at least every 4 hours at the end of life that you help the person to keep their mouth moist and comfortable, that you use a water soluble jelly to the lips rather than a petroleum base, that you wipe the mouth with chlorhexidine, or it can be an alkaline rinse, that's got baking soda and some water or club soda. Both of those will help the mouth to feel less uncomfortable. Next slide, please. And your goals at the end of life is that it's a modified palliative care. You're trying to keep the mouth tissues and tongue free of debris, bacterial, biofilm, and plaque, and you're trying to keep everything comfortable and clean and keep the mouth moist. Next slide, please. So we've talked a little bit about the best practice guidelines that the Registered Nurses Association has. Implementing best practices can help you revamp your oral care program if you're in a long-term care home or in a hospital. So we have, RNAO has a guideline on oral health that came out last year on supporting adults who require assistance with oral health. We have an end of life guideline that's focused on the last weeks and hours of life. And then we have another guideline on palliative care in the last year. All of these guidelines are free. Anyone can use them, even though they're produced by the Registered Nurses Association. They're for healthcare providers. Any healthcare providers. These products are funded by the Ministry of Health and Long-Term Care, who pays RNAO to develop these evidence-based resources that we can all use. In long-term care homes, they have the program that I'm involved in, which is the Long-Term Care Best Practice Program. We're around to help you implement these kind of guidelines, and we're more than happy to work on this issue because it's such a hot topic for some of us. There's lots of good resources out there. I'm sorry this is yellow, but there's a lot. If you put in long-term care resource toolkit, we have an oral health section. This is a project of the program that I'm involved with. There's other palliative care presentations on there. There's a Xerostomia handout and a list of more detailed list of all the drugs that contribute to xerostomia. There's some lovely oral assessment resources out there. My colleague, Ebo McDonald, and I did a series with Algonquin College students, or mostly Ebo and the students, where you can learn more about the different conditions that you would see at end of life. The South Australia website, that there's a link there, has excellent oral care resources with a nice little self-teaching tools there. There's also some self-teaching tools from the University of Manitoba. They have a dental school, so they've got some lovely resources. And Dalhousie School of Dentistry also has some just beautiful resources on oral care. We're always on the lookout for good stuff, because it's such an underappreciated sector for a lot of us, not for the dental hygienists in our lives. So then the next slide, please. Here's some articles. We've put the link. We didn't put the link to our article in Wounds Canada. We'll have to throw that up in the chat box. Anyway, yeah, sorry. Oh yeah, it is. It's the last one. It's Peachman Faust, that one. So that article is available to anyone. You just go on to Wounds Canada, the website, and you can access it there. We had a lot of fun with that one. And it's helped us to, come to more common language together on the issues for both nursing and dental hygiene. We coined the term the oral, the gum-tooth interface is the most important.
I like that, right? Yes.
Yeah, the most important part for you to pay attention to as a healthcare provider.
Right.
I think we're on to our last slide, which is our question slide. And we got a couple in the chat box there, don't we, Carol?
Thank you. Stephanie, can you let us know if we had any questions?
I sure can. Yeah, so going back a little bit earlier in the presentation, Norma had a question saying, I know there are medications to dry up saliva. Are there medications to cause more saliva? And would that help some of these illnesses?
Yes, in some cases it can, but as you know, with medications, there's always another side effect. So if you can resolve it with non-prescription products, which is another number of them on the market with regards to toothpaste and rinses that can be used to increase the saliva flow. And of course, take a look at the, as Heather has been saying, we've been looking at very closely at saliva or xerostomia, dry mouth and wounds, and take a look at what's happening with somewhere else in the body. Is there anything that's impacting on this? Heather, would you like to add to that?
Well, yeah, your overall health. Are you, is there something else going on that's contributing when you're starting to see problems in the mouth? I think we've got Nucine has her hand up, right? Good. Do you want to unmute?
Yes. Can I ask you a question?
Sure.
Thank you so much for the wonderful presentation. I have a question to ask. I don't know how practical currently is in long-term care homes. As far as I know, there is no daily oral care being provided to residents. So I'm not sure how you suggest, because from my own experience, when my mom was in long-term care home, many times I would go there and see her not eating, and then I would realize that her dentures are not in.
Well, I'll speak to that first, Heather. First of all, there are regulations in long-term care homes, in all of the long-term care homes in Ontario. If a person is supposed to, a resident gets their mouth cleaned twice a day, and that's in the regulations. There's a number of, as Heather and I can both tell you, there's a number of complications to this. It's a complex issue. It's not an easy fix. One of the things that I see is, as I mentioned in the presentation, some of these complex restored mouths, whether it's prosthetics built on implants or crowns and bridges, that's way beyond the realistic expectations of the personal support worker, who happens to be the person who is assigned the task of mouth care being seen as an activity of daily living. So that's one point. Another thing is that when often when residents have a bath and the worker is looking and they see problems with their nails, they immediately call somebody to come in and do that foot care for them. We haven't got to the point yet where that's recognized with regards to the mouth. The mouth is a very complex area, and these complex restorations need professional help. And so a couple of things, we need to get to the point where the workers say, this is beyond me, I can't do this, call in the professional to do it. And the other piece, which I keep harping on, is the fact that we need to get the oral health care professionals included in legislation, long-term care legislation.
Yes, because the question I have is that I don't think that's part of the routine check provided to residents.
It is.
On a
Well,
daily
it's supposed to be though. It's a required activity, and it's in the personal support worker inspection protocol. So it actually is supposed to be done. Unfortunately, what we've seen with COVID, it's the part that gets cut. It is not easy to do this oral care, not just from what Lynda said about restorations, but also if you have a resident with dementia who's fighting you and you only have like 2 or 3 minutes to do that oral care, it is extremely difficult. And so what Lynda and I did some research a few years ago where we looked at what was actually being charted, and people would put refused, and not understand, and just allow someone to refuse oral care for several days on end until there was actually, one of them we found a problem. One fellow had a tumor or a wound protruding through his cheek. That's why he wasn't getting oral care. So it's not easy to do in this time when homes due to COVID are short of staff. It's a task that gets cut, and that's problematic. The upside of this, though, if there is an upside, is that families can do oral care. You can help. This is a way that you can definitely help your relative in there, like just providing, helping brush their teeth. Like it might not seem like a big thing, but it is. And so we've got to do better. We need more staff in long-term care for sure. So this task can get done. And we also need a better way of getting help when it's these complex restorations, because it's my generation now that's coming in with all this fancy work done on their teeth. I remember a story in one of the homes where the resident had a post in the front tooth and the tooth had fallen off, the post was still there, and that RPN was absolutely determined to keep that woman's teeth clean, and she would dig around with a Q-tip and clean that spot out so that woman didn't have a problem. But you don't often see that kind of dedication to oral care.
Thank you so much.
You're welcome. So I think we got some more questions here in the chat for our last few minutes.
We do, and I just wanted to go back to one comment that I think Lynda already addressed quite nicely, where Sherry had shared an experience about her mom who passed away in August in long-term care, and partly due to COVID, and a result from her stroke and dementia, she was unable to do her own care, and then being in isolation. And she said when they were finally able to have a hygienist provide mouth care, her mouth was in bad shape. Unfortunately, though, she could afford the hygienist twice a week. But again, Lynda, going back to your point that it's a lot to expect for PSWs as an added task. And again, really advocating for a full-time dental hygienist for residents, having it in the Long-Term Care Act would be ideal.
Yeah, and advocating for enough basic care staff too.
I want to add one point too, with regards to that, with this period with COVID, it would have been a really beneficial time, I think, to have had oral health care professionals working, to have considered us as essential workers, because we could have identified some of the issues that were probably related to COVID. Now we've got people hypothesizing about the relationship between oral care and COVID, but nobody was actually there watching, and they could have been. And you know, it's related to the respiratory, and so it would make some sense, but we're hypothesizing now instead of having the evidence.
Can I just ask, is it now considered essential?
No.
That hasn't changed.
Oh, no, I'm sorry, but we can go in as in some cases, not all of them. And I'm just talking about Thunder Bay,
Right.
you know, as an essential, perhaps as essential caregiver, but that's different than being in legislation and so no, that the legislation hasn't changed yet, but yes, we have had some access.
Absolutely.
I think we got a couple more questions here, eh? About chlorhexidine and Princess Margaret mouthwash. I remember that when I worked at the cancer center. I just can't remember what goes into it. Do you remember? Do you know that one, Lynda?
Not off the top of my head, but it's very effective.
Yeah, what's included? I think it's still used.
Hi, ladies.
Thanks, Carolyn. We
hi.
got to acknowledge you as our co-author.
I'm just going to butt in on that, Princess
you.
Margaret. It's an antifungal, an antiviral, and an antibacterial. I've used it a few times with some clients, and I found that the residents' doctors are very inclined to collaborate with me to get that prescribed in some of my scenarios, and it's been very beneficial. You guys are doing a fantastic job.
Thanks, Carolyn. There's another question here about chlorhexidine. Can it be incorporated into a regular oral care regimen, or is it solely used for problems?
I could.
Sure.
Go ahead, Carolyn.
Cool.
It can be incorporated into a regular regimen. I actually use it, the folks that I see every week, and Carolyn, you can add to this if you want. I mean, that's my go-to, chlorhexidine and the dip and brush on a weekly basis. Yeah, that would be my short version on that. Carolyn, do you want to add to that?
Yeah, can you hear me okay?
Yep.
Yeah, I've done that with some of my clients as well. We put them on a regime where they're using a dip, and the staff is using a dip and sort of wipe method with it. And I just sort of keep a close eye. But those are clients generally that I'm seeing on a more regular basis, just as follow-up care. And again, I've seen really good oral response to that as well.
So Carrie's got a question here, wondering what chlorhexidine tastes like. It's unappealing. Does it make it more challenging, or is it?
I don't think it's totally unpleasant. No, it's sort of a minty flavor, a little bit of a medicinal hue to it, but I haven't had anybody reject it outright because of lack of taste.
No, nor have I. Nor do I.
Hello, I'm back.
Oh,
You're drawing to a close to this session. I know there's a couple more questions. I'm wondering if you can squeeze them as I launch the poll, the evaluation poll, which I would like to ask everyone to quickly fill out. It's very quick. I want to thank Heather Woodbeck and Lynda McKeown. Very informative. Lots of questions. I don't know if there's a way you like to handle these questions. I think we are going to give out the PDF presentation, and at the end there is some contact information. Is it fair to have people send you their questions?
Yeah. Send
sure.
along, yeah.
I'm welcome to. I welcome emails or any follow-up questions that they have directly.
Okay, so everybody, you can send your questions to them. Thank you very much. Here's a quick survey or a poll. If you want to answer one more, by all means, why don't you do so? And thank you.
Thank you.
Thank you for the opportunity.
Very much appreciated.
I guess I'm curious what PMM is. That a
That's the
different
Princess Margaret
right.
mixture or something? It's got mouthwash. Yeah, Jennifer's saying we use it a lot. We
Thanks,
can find
Jennifer.
the recipe.
we had a question earlier. I don't know if it was addressed. What's angular
Yeah,
chyle?
we talked about that being, it's an inflammation at the corners of the mouth. And Lynda, what's the treatment for that one though?
Well, that's usually a sign that they, well, I shouldn't say usually. It could be a sign of many things. Moistening and creams helps to some degree. You got some other suggestions for it, Heather?
No, that's what I was going to suggest.
Okay, good. I'm glad we're still on the same track.
Yep.
Good.
But it is a sign that there's a problem in the mouth, eh? Okay, someone
Well,
wants
there's
the recipe.
I would say it was a problem that there's a problem somewhere. Yeah, it's
Yeah.
a sign of an issue. And often
Cool.
it's dry, very dry, dehydration of some sort.
Yep. And we'll share the Princess Margaret mouthwash recipe. That's a request in there now.
Thank you, everybody who joined today. We will follow up with the presentation PDF, and this presentation is going to be posted on CERAH's YouTube channel. So look for that, and thank our presenters once again.
Oh, and again, thank you for the opportunity.
Thank you.
Yep.
Bye.
thank
We'll have
you.
to do a follow-up.
Bye.
Thank you.
Okay.
Bye-bye.
Bye.